Hello everyone, welcome to first part of the chapter Neoplasia. Neoplasia, it's a very important chapter. A proper conceptual knowledge on this chapter is required so that you can very easily understand all the concepts of tumor pathology that you are going to study in the upcoming chapters of the systemic pathology. So first of all, in this module, I am going to make each and every terminologies clear. Fine? Yes. What are the common terminologies you encounter in neoplasia? Neoplasia means new growth. Fine? Yes. So, all the tumor cells, okay, all the tumor cells have two components. Number one is the tumor parenchyma and number two is the reactive stoma. What do you mean by reactive stoma? Because these cells are, in tumor, what is the problem? That is, it is an abnormal proliferation of the cells. Am I right? In excess of the body's demands, the cells are undergoing proliferation. So, the reactive stoma which is made up of the connective tissue and blood vessels are required. Why? Because blood vessels are very important to provide nutrition, okay, to these cancer cells. And remember, these parenchymal cells will also stimulate the formation of some abundant collagenous stroma. This is what we call it as desmoplasia. One characteristic typical example for desmoplastic tumors are the stony heart or the serous tumors of the breast. What do you mean by benign tumors? Benign tumors are those tumors. Okay, actually see the neoplasm. The neoplasm means actually we use the term mainly for malignant tumors. Okay, for benign tumors we use the term benign tumors only. Fine. So the benign tumors means they are localized at the site of origin, so that we can very easily we can remove them surgically. So then coming to the naming of the benign tumors of the mesenchymal origin. Mesenchymal origin means cartilage, bone and other connective tissue. For example, fibroblast-like cell we called fibroma. Cartilaginous tumor we called as chondroma. Okay, benign epithelial tumors, the naming is a bit complex that we will see later. Adenoma means they are the benign epithelial neoplasm. Benign epithelial neoplasm which arises from the glandular tissues. Okay, yes. And then this benign epithelial neoplasms, okay, which arises from the epithelium, they may produce some finger-like or warty projections from the epithelial surface, and they are called as papilloma. Sometimes they form large cystic masses, that is what we call it as cystadenomas. And sometimes this benign neoplasm, they may change malignant. Okay, yes. Okay, and sometimes this benign neoplasm, they may project above a mucosal surface, as we can see in case of gastric and colonic lumen. We have something what we call it as polyp. Polyp is nothing else but an abnormal protrusion of the epithelium, okay, into the mucosal surface, and that is what we call it as adenomatous polyp. What is we call it as adenomatous polyp? Okay. Then we have something called as malignant tumors. See, malignant tumors, the hallmark feature of malignant tumors are metastasis. That means they have the ability to spread to distant sites. That is why crabs, they have a tendency to adhere to the substance or to the prey. Am I right? Yes. So that is why we call them as cancers. Cancers means crab. So you can see here, this is the colonic polyp. So this is the normal mucosa, and you can see a polyp. This large polyp has been protruded from the mucosal surface. Okay, yes. And remember, it is attached to the mucosa by a distinct stalk. Okay, this is the stalk. Okay, this is may or may not be present. So since it is stalk is present, we call them as pedunculated. Okay, we call it as pedunculated. And suppose if the stalk is absent, we call them as sessile. Okay, we call them as sessile. So I hope this point is very clear for you. Yes. Then malignant tumors which are arising from the mesenchyme. Okay, mesenchyme, benign tumors I told, no, chondroma, fibroma. So suppose if the malignant tumors are arising from the mesenchymal tissues, we call them as sarcomas. For example, fibrosarcoma, that is nothing else but the malignant variety of fibroma. Chondrosarcoma. Similarly, remember leukemias, all leukemias, okay, all blood forming leukemias or lymphomas. Leukemia means from the blood forming cells. Lymphoma means from the lymphocytes or the precursors of lymphocytes. And the malignant neoplasms which arises from the epithelial cell origin, we call them as carcinomas. Sarcoma means from the connective tissue. Squamous cell carcinoma, which are that is the tumor cells will why it is called as squamous cell carcinoma? Because the tumor cells resembles the stratified squamous epithelium. Adenocarcinoma, the neoplasm, the epithelial cells will grow in the form of what we call it as a glandular. Adeno means gland. Fine. See, this is a mixed tumor. This is a mixed tumor of the parotid gland. This is what we call it as pleomorphic adenoma. pleomorphic adenoma. Pleomorphic means mixed, okay, or varieties. You can see all the components here, okay. You can see the cartilageous component, you can see the mesenchymal, okay, that is the fibroblastic component is there, so all there, and of course you can see the epithelial components. So the epithelial component, fibroblastic components, cartilage, everything is present. That is why it is called as pleomorphic adenoma of the salivary gland. It is also called as a mixed tumor of the salivary gland. Fine, yes. So mixed tumor. So the classical example of the mixed tumor, it is having a myxoid stoma. Myxoid stoma means it is having an epithelial component. It may have a cartilage or a bone. It may also have a fibroblastic component. So that is why they are called as mixed tumors. And the classical example of mixed tumor is what we call as the pleomorphic adenoma of the salivary gland. What do you mean by? And remember this. Most okay, all this okay variety or the almost all varieties of these mixed tumors have only single germ layer, and the most characteristic exception of this is what we call it as the teratoma. Okay, usually I told that either single germ layers. What are the germ layers? Mesoderm, endoderm, and ectoderm. So usually either of this what thing will be present. Either of this what mesoderm or endoderm. Either of the one germ layer will be present. Whereas in the exception is called as teratoma. In teratoma we can see more than one germ layer, or in most of the cases you can see all the germ layers. Okay, the teratomas are characteristically present in ovary and the testis, and they originate from the teratoma stands for sacrococcygeal teratoma. That means from the pluripotent germ cell or from the primordial germ cells. They are totipotent. They can give rise to all the three germ layers. And the best characteristic example what you can see here is the teratoma of the ovary. You can see here teeth. Okay, teeth is present, hair is present. Okay, sometimes the bones are present. So all the components are, all three germ layers will be present. Okay, that is what we call it as cystic teratoma, also called as dermoid cyst. Okay, yes. Oh, you can see here sebaceous gland, even tooth structures, bone, everything can be seen. Even cartilage can also be seen within the teratoma. Teratoma means all three germ layers will be seen. Okay, fine. And next is two important terminologies you have to undergo. What very important, there one is called as hamartomas and another one is what we call it as choristoma. One is what we call it as hamartoma and another one is what we call it as choristoma. Okay, yes. What do you mean by hamartomas? See, hamartoma means, for example, lungs. Okay, lungs have alveolar epithelial cells. Lungs have alveolar epithelial cells. Suppose whenever there is an abnormal excessive proliferation of alveolar epithelial cells within the lungs itself, that means this neoplasm is indigenous to lungs. Okay, because this normally lungs only have alveolar epithelial cells. There only these cells undergo excessive proliferation. So that is what we call it as hamartomas. So hamartomas are disorganized masses of cells which are indigenous to the involved tissue. Very, very important term. The best example I can mention here is pulmonary hamartomas. What is it? Pulmonary hamartomas. Pulmonary hamartomas. Okay, yes. And the next is what we call it as choristoma. It is heterotopic. Heterotopic means misplaced cells. For example, I am getting pancreatic tissue in the stomach or in small intestine. We have a condition called as Meckel's diverticulum. Meckel's diverticulum. In Meckel's diverticulum, you can see abnormal gastric. Meckel's diverticulum, it is actually from apart from the small intestine only, but we are getting abnormal gastric or pancreatic tissue. So these tissues are usually, they are not found in these regions, but they are misplaced. Okay, that's why we call it as heterotopic. So that is what we call it as choristoma. So just remember these two terminology. One is called as hamartoma and one is called as choristoma. Okay, now let us see these are important from the mesenchymal: fibroma, lipoma. The malignant is fibrosarcoma, liposarcoma, blood vessel hemangioma, angiosarcoma, lymphangiosarcoma, then meningioma, invasive meningioma. Okay, see, these are exceptions. Meningioma, there is nothing called as meningiosarcoma, it is invasive meningioma. Then leukemias and lymphomas, they are not benign, they are always malignant. Then leiomyoma, leiomyosarcoma, rhabdomyosarcoma, squamous cell papilloma, squamous cell carcinoma, nevus, malignant melanoma, bronchial adenoma, bronchogenic carcinoma, hepatic adenoma, hepatocellular carcinoma, hydatidiform mole, okay, becomes choriocarcinoma, and testicular tumors almost all are malignant, seminoma and empyreal carcinoma. Pleomorphic adenoma, we have mixed and it becomes malignant, and even Wilms tumor, there is no benign variety, only malignant variety, and teratoma, immature teratoma. See, remember, mature teratoma is is benign, whereas immature teratoma, okay, this is a very important point. I'm going to highlight with green color. See, mature teratoma is benign, whereas immature teratoma is malignant. Just for now, for it will help, okay, knowing this table will help to solve some of the MCQs, because we are going to see each and every of these tumors, everything in the subsequent chapters. Fine. Yes, you can see here. This is the leiomyoma. Okay, now let us see what is differentiation and what you mean by anaplasia. See, differentiation means it refers to the extent which, okay, that means the neoplastic cells. We have neoplasm, okay, and how far this neoplasm is what resembles the normal tissue. For example, we have uterus. So this is the leiomyoma of the uterus. What do you mean by leiomyoma? It is nothing else but a smooth muscle tumor of the uterus. Am I right? You can see in this picture, you can see spindle-shaped arrays of the neoplastic smooth muscle cells. But once you look at this picture, you will see that this looks almost like a normal uterus. So what does this mean? This means that this tumor is well differentiated. Well differentiated means it looks almost similar to that of the normal histology of an uterus. That is what we call it as well differentiation. What is the importance to know whether it is well differentiation or poorly differentiation or moderately differentiated? It helps in prognosis. Well differentiated cancers have always good prognosis, very good prognosis, and they respond very well to the treatment protocols. Okay. And so, suppose whenever there is a lack of differentiation, both morphologically and functionally, that is called as anaplasia. So, when someone asks you to define what is anaplasia, don't simply say lack of differentiation. Morphologically and functionally, if there lack of differentiation is called as anaplasia. So, lack of differentiation, both morphologically and functionally, we call it as anaplasia. Okay, so you can see here, this is a benign tumor. This is a well differentiated benign tumor of the thyroid gland. See, once you look this is almost how the normal thyroid gland will looks. Okay, see, this is a well differentiated squamous cell carcinoma of the skin. This is how normally a skin histology will looks like. So all these are examples of well differentiated carcinomas. Okay, yes, fine. So once this is done, what are the features of neoplasm? What are the histopathological features of neoplasm? Okay, number one is pleomorphism. What do you mean by pleomorphism? Yes, what do you mean by pleomorphism? See, this is an anaplastic tumor. You can see there is a cellular and okay, that we will come to that. So what do you mean by pleomorphism? It refers to the variation in the cell size and shape. Am I right? You may have hyperchromatic nuclei. There will be alteration in the shape and sizes of the different cell. There will be giant cell formation. So all this indicates pleomorphism. Abnormal nuclear morphology. Remember children, there is normally the nuclear cytoplasmic ratio is 1:4 to 1:6. Whereas in case of neoplasm, it is 1:1. That means the nucleus and cytoplasm both will be equally large enough. Fine. Yes, there will be irregular and clumping of chromatin. That is what we call it as hyperchromatic nuclei. So this is a malignant tumor or adenocarcinoma of the colon. Okay. Yes, you can see here the glands are. See, you can see I am drawing with black color. The glands are irregular in shape. See, these are irregular in shaped glands. Okay, these are irregular in shaped glands. Okay, they don't resemble the normal colony glands. Okay. Yes. But you can see that the gland formation is there. So I can say this is moderately differentiated. Poorly differentiated means you cannot identify even the organ. You can't identify. See, for example, this is an okay, for example, yeah, this you can imagine this condition. Can you identify what tissue it is? No, you can't identify this tissue. This is a poorly differentiated. You can't even identify what organ it is. Whereas in this case, you can identify, yeah, we have a lot of glands, but these glands are not regular. Okay, they are irregular in size and shape. That is why we are calling this as moderately differentiated. Okay, and you can see here the cellular nuclear variation can be seen. Okay, see, and you can see some appearance. This is called as abnormal mitosis, also called as tripolar mitosis or tripolar spindle. Okay, tripolar spindle, atypical bizarre mitotic figures you can see here. See, you can see the atypical bizarre mitotic figures. I am drawing atypical bizarre figures, and you can see there hyperchromasia can be seen. Okay, yes, see here again, this is a pleomorphic tumor of this. You can see the this is the rhabdomyosarcoma, children. Okay, rhabdomyosarcoma, you can see the pleomorphism. You can see the pleomorphism, hyperchromatic nuclei, tumor giant cells. What you are seeing here, no, these are all tumor giant cells. Fine. Yes. So mitosis, you know, mitosis, the most important feature of malignancy. Okay, these are all these features are the features of malignancy. Okay, yes. So lack of differentiation, all these are the features of malignancy. So what will happen in malignancy? There will be atypical bizarre mitotic figures. There will be loss of polarity. What do you mean by loss of polarity? See, usually the cells will be arranged perpendicular. The cells will be arranged, as you can see in this figure, the cells will be arranged perpendicular to the basement membrane. When this arrangement is lost, we call it as loss of polarity. Fine. Yes. Okay, then next let us come to some other important terminology. What is metaplasia? Already metaplasia I have told you, it is the replacement of one type of cell with another type of cell. Whether it is reversible or not, answer, it is reversible. It is nothing else but a cellular adaptation. Whereas dysplasia is irreversible. It is disordered growth. It is disordered growth. There will be hyperchromasia. There will be high nuclear to cytoplasmic ratio. Okay, but the basement membrane, everything will be normal. Whereas okay, yes, in carcinoma in situ, what happens when the dysplasia is very severe, the tumor cells will invade the whole thickness of the epithelium, but the basement membrane remains intact. That is what we call as carcinoma in situ. We use carcinoma in situ as a term in case of skin cancer, breast cancer, bladder cancer and uterine cervix. Whenever there is a breachment of basement membrane, we call it as pakka or pure malignancy. Okay, pure malignancy means breachment of so although dysplasia may be precursor to malignant transformation, it does not always progress to cancer. Very, very important statement. That means the dysplasia, it is a precursor to development. It may, but it may not progress to cancer. Okay, yes, please, it's a true or false statement. So you can see the carcinoma in situ and okay, yes, you can see the carcinoma in situ whereas the basement membrane is intact. Okay, and there is no tumor in the subepithelial tumor. Here you can see there is no tumor, only the tumor is present here. Okay, I hope you understand all these terminologies. Fine. Then what do you mean by local invasion? So I told you that the cancerous cells will undergo proliferation, it will undergo invasion, it will destruct the surrounding tissue, finally it will go for a systemic spread. That is actually what we call it as, what do you call it as metastasis? No, that is not metastasis. That is called as local invasion. What do you mean by metastasis? I will give the definition later. Now, local invasion means it is going to destruct the adjacent surrounding tissue. Okay, and it may even go for a systemic spread. So this remember that is the local invasion. The extent of local invasion, it depends upon some important properties of this cancer. Number one is the tumor capsule. You know, the tumor capsule is made up of extracellular matrix made up of fibroblast. So whenever this undergo damage, this may leads to expansion of the tumor. But there are some other conditions like hemangiomas. Even though they are uncapsulated, they may still leads for local invasion to the skin and the liver. Fine, yes. And in contrast, so all these are conditions with the benign tumors. Whereas in malignant tumors, no, these malignant tumors have very poor demarcation from the surrounding tissue. Okay, and they are also usually, they looks like pseudo encapsulated. We can't say whether they have capsule or not. And another most important thing, remember, for malignancy and benign, how will you different? What is the characteristic feature which distinguish benign tumors from malignant tumors? The answer is metastasis. That is the first answer. The second differentiation is local invasion. Local invasion is a more characteristic property for malignant tumors than benign tumors. What is metastasis? It is the spread of tumor to a sites which are physically discontinuous with the primary tumor. This definition is important, and even which is unequivocally marks as a tumor as a malignant. So no benign tumors will undergo metastasis, but malignant tumors will always metastasis with the exception of two conditions. One is called as basal cell carcinoma, also called as a rodent ulcer. It is a carcinoma of the skin, and another one is called as glioma. Okay, which is the cancer of the CNS. Okay, which these are the two cancers which never undergo metastasis. Very, very important. See, this is a fibroadenoma of the breast. Okay, you can see the encapsulated tan colored tumor. Okay, you can see the tan colored encapsulated tumor which is very sharply demarcated. You can well differentiate it from this is the normal breast. This is normal. This is the cancer. I am writing C. Fine. Yes. So this is the microscopic view. Okay, fine. See, at the same time, this is an invasive ductal carcinoma. You can't identify where is the normal breast. Okay, this is invasive ductal carcinoma of the breast. There will be complete infiltration of the surrounding breast tissue. There is stony hard, and it will be stony hard on palpation, and there is no demarcation from the surrounding tissue. Fine. Yes. Remember, basal cell carcinoma and glioma, they undergo metastasis. Coming to the pathways of spread, children. Okay, there are three important pathways of spread. Number one is called as the direct seeding through the body cavity, lymphatic spread and hematogenous spread. So direct seeding of the peritoneal body cavities occurs in case of pleural, pericardial, subarachnoid, joint spaces and peritoneal cavity. In cases of carcinomas which arises in the ovary, it may undergo, for example, ovarian cancer, no, it may undergo direct seeding into this. Any tumors of this abdominal viscera, they may also undergo direct seeding into the peritoneal cavity. Okay, yes. So whenever there is any tumor There is a mucus secreting tumors of the ovary. They will fill the peritoneal cavity with a gelatinous neoplastic mass. That is what we call it as pseudomyxoma peritonei. Pseudomyxoma peritonei means what? Why it is called as pseudo? Because actually it is not the cancer of the peritoneal cavity, but it is a cancer from the ovary which reaches and which produces a fibroblastic and a gelatinous mass deposit within the peritoneal cavity. This is what we call it as pseudomyxoma peritonei. Pseudo means what? False. Myxoma means what? Fibroid. Myxoma means fibroblastic, or what we call fibroblastic proliferation. And peritonei means in the peritoneal cavity. So pseudo plus myxoma plus peritonei, pseudomyxoma peritonei, because of the ovarian cancer or appendicular cancer. If you ask me, out of ovarian cancer and appendicular cancer, which is more predisposable or which is having a very high risk of producing pseudomyxoma peritonei, my answer will be appendicular carcinoma. Okay, because it will have more risk of producing pseudomyxoma peritonei. Fine, that is what we call as a direct seeding into the body cavity. The next one is what we call as a lymphatic spread. Remember, the lymphatic spread is the most common pathway for the initial dissemination. It is the most common pathway for initial dissemination of the carcinomas. Fine, yes. Lymphatic spread. For example, the breast can be divided into 4 quadrants: upper outer, upper inner, lower outer, lower inner. Fine, yes. So we have these are 4 quadrants of the breast. So this breast, the breast will undergo metastasis to the lymph. So the first lymph node which gets the cancer cells or which gets the lymphatic drainage from the neoplastic growth, that is what we call as sentinel lymph nodes. So lymphatic spreads are this is what we call as sentinel lymph node. Then we have the hematogenous spreads. Hematogenous spread is, so for carcinoma is concerned, as far as carcinomas are concerned, it is the lymphatic spread that is a major pathway for spread. Whereas in case of hematogenous spread, that means via the blood, it is most characteristically seen with the sarcoma, but it is also seen with the carcinoma, but most characteristically with the sarcoma. Fine, yes. Okay, you can see, this is liver started with the metastasis. Liver is one of the common sites. Liver, lungs, all these are the common sites for metastasis. So this is a table showing difference between benign tumors and malignant tumors. Benign tumors are well differentiated. They are slow progressive mitotic figures. All these are rare, whereas this what is tripolar figures, bizarre, atypical, bizarre mitotic figures, hyperchromasia, pleomorphism, anaplasia. All these are characteristic features of malignant neoplasm. Fine. And then coming into the local invasion. Local invasion means what I told you, local invasion is different from metastasis. Yeah, local invasion in case of benign tumors, there will be a well demarcation between the tumor and the surrounding tissue. Whereas in case of malignant, there is poor demarcation and metastasis is absent and it is very frequent. There are only 2 cancers which does not undergo metastasis. One is called as the basal cell carcinoma of the skin and the one is called as glioma. Fine, yes. And metastasis can occur through blood via what? For example, the prostate cancer and thyroid cancer, they can undergo metastasis to the central nervous system and vertebra, or to the central nervous system and vertebra via the paravertebral venous plexus of Bateson plexus. And the renal cell carcinoma, as far as the testicular carcinoma, they can undergo metastasis to the kidney or vice versa via the renal vein. Fine, yes. So these are about some of the important terminologies. Okay, that is a benign and malignant tumor. Remember, anaplasia is nothing else but how you define anaplasia. It is a morphological and what functional lack of differentiation is what we call as anaplasia. And what is the first feature which distinguishes between benign and malignant tumors? Your answer should be metastasis and the second answer should be local invasion. Fine, yes. So with this, I hope we have finished the first part of neoplasia. Okay, in the second part, we will be discussing about the epidemiology of the cancer and the molecular mechanism and all other topics. So I hope this section has been useful for you. Fine, thank you.